Thank you for the opportunity to present here. It's really a pleasure to be here. And I think Sue did a great introduction. This is about the Ohio's BCCP program, the Breast and Cervical Cancer Early Detection Program. We'll call it BCCP from here on. And again, it's very much work in progress. You'll see a lot of loose ends in what I'm going to present, and we're in the process of finalizing some of the analysis and then starting some other parts of the analysis, so please bear with me. So, of course, the underlying rationale is that breast cancer is amenable to screening, and many women are diagnosed in advanced stages. And cancer stage at diagnosis is one of the most important prognostic factors, and advanced stage diagnosis means unfavorable prognosis. And the BCCP program has been established to promote screening in low-income women with no insurance. How many of you are familiar with the BCCP? Maybe most of you. So here's the description of the BCCP, and this is a snapshot of the brochure that is shared by the Ohio Department of Health. It starts by saying, are you age 40 or older? Are you uninsured? Do you have limited income? And therefore you may qualify for a free mammogram and Pap test. And then it goes on in the brochure to describe the BCCP program. It's a statewide program that offers screening and diagnostic testing at no cost to eligible women. And here are the services that they provide: pelvic exam, Pap test, clinical breast exam, mammogram, case management, and also diagnostic testing once they find something abnormal. And who is eligible? Women who live in households with incomes less than 200% of the poverty level, have no health insurance, and therefore, by definition, and because Medicare kicks in at age 65, then this is going to be limited to women age 40 to 64. So at age 40 or older, they can get Pap test, pelvic exam, and clinical breast exam, but age 50 and older, they're qualifying for mammograms. What is also very nice is that if a woman is diagnosed with cancer through the BCCP, then they are eligible to apply for BCCP Medicaid, which provides Medicaid coverage for their cancer treatment and other healthcare needs. And there was a scare, I think, that the BCCP program may be eliminated through this new budget, but I heard that wasn't the case, and so that was a great relief. So that's BCCP in a nutshell. And really just the overarching goal of this project is to evaluate Ohio's BCCP program. This was a grant funded by the American Cancer Society, and as Sue mentioned, she was a co-investigator on this project. There are many aspects by which we are evaluating the program. What percent of eligible women does the BCCP reach? Is it 100%? Is it 5%? What is it? Are there regional variations in the way by which the BCCP program is managed? And then there are these two aims are fairly involved in that we will be looking at women who are diagnosed with with cancer and then transition over to Medicaid, and then we compare their outcomes between them and other women who may have joined Medicaid as they're diagnosed with cancer. And then in the last aim, we'll be looking at whether women who have been enrolled in the BCCP program carry with them some kind of a positive behavior in terms of screening and treatment adherence as they compare with their low-income Medicare beneficiary counterparts. So in this talk, we will not be talking about these two aims at all. We'll be more focused actually at even one step back, because what we would like to do before we even start looking at great depth into the BCCP program, we'd like to gain an understanding of what the correlates are for advanced stage cancer. Who are the women who are diagnosed with advanced stage cancer? And would like to not only just look at the individual level correlates, but also at factors at the contextual level, where they live. Does that make a difference? Some of the characteristics of where they live, does that make a difference? And see whether there are factors at the contextual level that are also associated with advanced stage cancer. Of course, we do this because once we identify these factors, then we are better equipped in terms of targeting our screening programs to people who are in greater need. So here's the map that Sue was referring to earlier. It's the data infrastructure that we built to address our study aims. But basically what this does is, this is our study population, which is a combination of women who have received services through the BCCP and women who are diagnosed with breast cancer. To this study population, we look at many different parameters. So we bring in data from the behavioral risk factor surveillance system, and I'll go through some of these measures in a minute. We bring in some variables from the area resource file. The area resource file is a incredible data resource, very rich, that is developed by the U.S. Census and labor statistics. And they bring in, at the county level, a lot of data on the population, breakdown of the population, but also availability of healthcare resources at the county level. To this, we have also added some primary data collection. As Sue mentioned, she conducted a survey of regional BCCP directors. And here we wanted to really look at variations in the way that the BCCP program is managed across the state. Are there variations? Do people do things differently in the northeast versus southwest, etc.? And eventually what we'd like to do is look at whether that kind of variation has any bearing on the outcome. And our outcome, really, the big outcome of interest is advanced stage cancer diagnosis. We would like to reduce that to the extent possible. So this is this part of the data, and then the two aims that we'll not be talking about today, which is looking at when BCCP women transition to Medicaid, and then they become age eligible for Medicare and they transition to Medicare. We have linked Medicare and Medicaid data to our study population, and we'll be digging in the data fairly soon.
And quick question, being new to Ohio, is there a central repository in the state that does the linking for you, or you have to do the linking?
We have to do the linking. Don't we wish? Great question. So for the purposes of this discussion, our objectives are now to examine the occurrence of advanced stage cancer in Ohio in a multi-level context. So as I mentioned, we'll not be only looking at the individual level factors, but also at the contextual level factors. Where they live, what are the attributes of where they live, etc. And eventually where we would like to be is be able to identify geographical hotspots with greater incidence of advanced stage cancer. So if you're at the Department of Health or at a community organization that cares about cancer screening, and somebody came to you and said, you know what, this is the neighborhood where we're finding a lot of advanced stage cancer interest, that's where we'd like to target your screening efforts. Our hypothesis is that area level attributes are associated with advanced stage cancer even after we adjust for individual level characteristics. And there are significant cross-level, individual by area level socioeconomic measures, cross-level interactions. So meaning that, for example, a younger woman living in this neighborhood would have a different likelihood of being diagnosed with advanced stage cancer rather than this other, if she was in this other neighborhood, for example. So for this particular purpose, we use the Ohio Cancer Incidence Surveillance System. We call it the OCIS. It's data from 2005 to 2009. We used that these years because some of our other data sets are also from that time period. So the OCIS is, it's been developed, it's been in place since 1991, and by law, all of the incident cases of cancer that are diagnosed among Ohio residents are to be reported to the OCIS. So it is supposed to be fairly complete in terms of the number of cases. It carries a lot of different variables. It includes identifiers, which we use later to link up with Medicare and Medicaid data. It carries some demographics, so we have age, we have race, we have marital status, but we also have the street address at the time of diagnosis. And the street address is geocoded. And geocoded means that you can obtain longitude and latitude, and by doing so, you can then identify the census block group and the census tract where the person resided at the time of diagnosis. So, as we identified the census block group and the census tract level, we were able to link with the American Community Survey, which is an offshoot of, or a byproduct of the U.S. Census data, and it will include a lot of data on socioeconomic measures, poverty, unemployment, educational attainment, female-headed household, etc. Then we also obtained a database from the Ohio Department of Health that identified for us census tracts that are medically underserved. So there are areas and there are populations that are medically underserved, and we'll go over the definition in a minute. And it has several criteria. One of them, we'll put them in that we'll designate them as medically underserved. So I believe it's low supply of primary care physicians, high infant mortality, and a high proportion of older people living in that particular census tract. And then we also use the Ohio Behavioral Risk Factor Surveillance System from 2005 to 2009. And from there, we obtained a lot of different measures. Just to mention a couple, what is the proportion of women in this particular age group, for example, who did receive mammography in the past 2 years? Who are the number of women who were who had low incomes and did not have health care coverage? Things like that. We obtained them from the Ohio BRFSS. Any questions and comments? Please feel free to stop. So our study population consisted of women who were diagnosed with incident invasive breast cancer during the years 2005 to 2009. Those are only invasive. We did not include the in situ cases. Our outcome variable was advanced stage cancer, and we define advanced stage cancer as being regional or distant stage cancer at diagnosis. And the proportions that we got was by adding up distant plus regional stage cancers divided by the total, but excluding unknown stage or unstaged cancers. And this is a category in the SEER summary stage that's really interesting to me. It's assigned to a case that has not been fully evaluated in terms of extent of disease, extent of disease being cancer. So for whatever reason, if a woman, in this case a breast cancer patient, did not receive a full evaluation to see what stage cancer she has, then it is assigned unknown stage cancer. And we've done some studies on this. This is not randomly distributed. This is there are very specific factors that are associated with unknown stage cancer. One of them is old age. We have found that race is also associated with unknown stage. Disadvantaged women, low-income women have unknown stage cancer. And also, the sicker a patient is, the more likely they are that they will have unknown stage cancer. So in one of our studies, we looked at nursing home patients compared to community-dwelling women who receive home health care versus community-dwelling women who do not receive home health care. And there was a very clear gradient. Those in nursing homes are most likely to have unknown stage disease. So we never just exclude these cases without first analyzing and seeing who they are, and then we exclude them and we define advanced stage cancer accordingly.
Siran,
Yeah.
why would that happen? Would that just be they just stop? I mean, they determine the person has cancer, but then they just stop there because of the age, or?
Well, we need to go a little deeper into our analysis to really find out what happens afterwards. I've heard some anecdotal comments from clinicians to say, okay, so I find out that this woman in nursing home has breast cancer, and then I just put her on tamoxifen. I'm not going to do anything else. Or, sometimes they might undergo surgery just to remove the tumor and then they stop there. But I don't think that there has been a systematic study to say exactly what happens to patients who have unknown stage cancer. What is interesting, though, is that when you look at the survival curve, and a lot of people think unknown stage cancer is when it is so clear that people have metastatic disease, we're not going to do anything to them. But if you look at the survival curves for regional stage cancer, distant stage cancer, unknown, and local, of course, you see that the survival curve for unknown stage cancer is between the regional stage cancer and distant stage. So those who are diagnosed with metastatic disease are worse off than those with unknown stage disease. And I think it's wrong to assume that everybody with unknown stage disease is just doomed to fail.
Right.
I have a question.
Yes.
You said that, and I might be paraphrasing this, please correct me. You said that in the nursing homes, that there's a higher number of, and does your research indicate why that might be?
Well, we don't know exactly. I think that there are a lot of unanswered questions. We know that it happens more in patients who are sicker, who have other priorities in their health care, and then this patient is really maybe cognitively impaired, maybe functionally impaired, maybe there's a lot of different things going on with them, and by the way, he or she was just diagnosed with cancer. What do we do with the cancer, kind of thing? Or it may well be, and we don't know to what extent that happens also, that the family might say, no, we don't want to do anything.
So as far as breast examinations, and I know I might be getting off the subject a little bit.
How is it diagnosed? Is that your question?
Well, it seems that that's not taking place, and maybe that's an opportunity for some kind of intervention, either with the family or something, because I know there may be issues with providing that on a monthly basis.
This is a very interesting point, and I don't know all the answers. I think that it's really important for all of us to think about these issues. But in a nursing home setting, I don't think that screening happens. I think cancer is probably diagnosed in a crisis situation. In the case of breast cancer, maybe as they're bathing the patient, all of a sudden they realize that there is a visible change in the shape of the breast, and they say, oh, there may be something here, or skin retraction or something like that. But these are excellent points, and I don't think these things have been addressed. And I think it goes more into the philosophy of screening as well. So
It's another seminar.
definitely, yeah, definitely something to discuss in the future. Okay, so these are the individual level variables that we are examining. So we definitely look at age, we look at race, which we categorize as African American, Caucasian, or and here we combine all other races and ethnicities together because in Ohio we have a rather small number of patients in this race ethnicity category. For age, this is the breakdown that we developed, and we created this group purposefully because this is, eventually we would like to take this into the BCCP evaluation, and that's really age eligibility range for BCCP. For marital status, we group them as married and non-married, and then here are the census data that we picked up at the census block group level. So when you look at the census data, you have data at the at different geographical levels, but the census block group level is the smallest geographical area for which you can have census data. And so because it is the smallest geographical area, and it's supposed to be fairly small, then what we did is we used these data to approximate the census measures to that of the individual level. Okay, so we thought that if the poverty level in this particular block is X, then we assume that the person living in that block also has that level of income. It's basically, or employment status, or high school education, or whether they live in a head household. Now, this is in contrast to the contextual level census data. We use the census tract level, which is a larger geographical area than the census block group, and we got the same measures at the census tract level as well. We also looked at the county of residence, whether it's metro, non-metro, or Appalachian, and then we talked about the medically underserved population. This is the one that I omitted earlier. So these are the criteria that qualify a specific area to go into to become an MUA. So it's low supply of primary care physicians, high infant mortality, high poverty rate, and or high proportion of elderly population.
I have a question on this individual level. So if unemployment was 23%, how did you define that for an individual?
That's a great question. So what we ended up doing is we aggregated measures across census block groups and across census tracts, and then we took quartiles. Once we aggregated them and we looked at the distribution statewide, then we took quartiles in these measures. And then we said this particular person lives in a census block group that has these attributes, and then in a census tract that has these attributes. That's how we did it. We did not give point estimates. Any other questions? These are some, I mentioned earlier that I used the PRFSS data to get some other variables of interest, and we were basically interested in access, healthcare access measures. So in addition to having had mammogram in the past 2 years, do you have a person you think of as your personal doctor or healthcare provider? Was there a time in the past 12 months when you needed to see a doctor but could not because of cost? So cost was prohibitive, they couldn't go see the doctor. Do you have any kind of healthcare coverage, including health insurance prepaid plans such as HMOs or government plans such as Medicare? And by the way, even Medicaid, they should also say Medicaid. So if they're on Medicaid, they're also considered not to have health coverage. So these are some of the variables that we considered in our analysis as well. So our results, we had a total of 40,000 women, 192 with invasive breast cancer during the years 2005 to 2009. Here's their age breakdown. We had less than 5% who were age younger than 40 and about 7% who were 85 plus. A little over 10% were African American and the rest, the vast majority were Caucasian, 2% other. And marital status was about 53, 54 to 46%. So first we looked at the unknown stage or unstaged cases before we removed them from the analysis. And as I had mentioned earlier, we see that where we see the highest proportion of unknown stage cancers is really the older population. As patients grow older, the proportion of unknown stage cancers goes up as well. Not much difference by race, but very different by whether it's by marital status, whether a woman is married or not married. And this is really a reflection of psychosocial support. A family member saying, no, we would like her to be staged, or so this is why I was saying that it can be proxy for many different things, unknown stage cancer, but we really don't know exactly what all this means. So from this point onward, we have removed the unknown stage cancers, and we're strictly looking at advanced stage cancer. So it's distant or regional stage cancer compared to the total. And what is striking here is that the proportion of advanced stage cancer is highest in the youngest population, which is before 40 years of age. This is before any screening program goes into effect. Goes down to 43, 39, and plateaus about to 1/3. So this, we've been spending a lot of time on this 51%. Trying to figure out who it is. By race, we see again the level of disadvantage in African American women, 51.5, Caucasian 43.5, and then women of other race ethnicities 39.5. By marital status, not much difference. We saw a big difference by unknown stage cancer, but not by advanced stage cancer. And this is at the Census Block group level. So, like I said, we use the Census Block group level measures to approximate the individual level measures. And as we discussed earlier, so this is all broken down by quartiles. And for all of these measures, so we have percent with incomes below the federal poverty level, percent women with no high school diploma, percent unemployed, and percent living in female-headed household. And Q1 is better, best, Q4 is worst in this case. So what do we see? It's pretty consistent, except for unemployment. We start off with 35% and we go up to 40%. So what this is saying is that women in census block groups that have the highest level of poverty have 40% of them are diagnosed with advanced stage cancer, compared to women who live in the lowest quartile. 35% of them are diagnosed with advanced stage cancer. The numbers are very similar for women with no high school diploma. A little different for unemployed. This doesn't quite touch the 40%, but it's also the same for the female-headed household. Now this is at the census tract level. We see just a little bit higher than 40% when we look at the census tract level, but basically the same pattern, going from 35 to 42, 41, 42, the same thing all over. And then this is the statistic for MUA and MUP, medically underserved areas or medically underserved populations. And for those not residing in medically underserved areas, again, the proportion of advanced stage cancer diagnosis is about 35%. Goes up just a little higher than 40% for those who live in medically underserved areas. Now, I'm going to ask you to bear with me a little bit. This is a little too busy. But what we try to do here is to feed individual level and contextual level variables in regression models. Okay. And because we are dealing with two different levels, so an individual who lives in a neighborhood, then people living in the same neighborhood would share common characteristics, so we needed to use what we call hierarchical modeling. And so, which is why you see here individual level characteristics, and then here you'll see contextual level characteristics. So, but we're including the individual and contextual level variables in the same model. But remember how I showed you poverty and no high school diploma and unemployed and living in a female-headed household? These are all very highly correlated variables, and so we could not include all of them in one model. We had to pick one measure at a time. And so what you'll see here is that in the first model we accounted for poverty, in the second model for low educational attainment, in the third model we looked at unemployment, in the fourth model we looked at female-headed household. And it's the same measure at the individual level and at the contextual level. Okay, did I lose anybody in that one? Okay. So, however, we kept, at the contextual level, we kept the medically underserved area in the models because we thought that was really important. So what are the findings telling us? First of all, in terms of age, and our reference category is the 50 to 64 age group. And consistently across all the models, no matter which SDS measure you consider, being younger is associated with a greater likelihood of being diagnosed with advanced stage cancer. And the highest odds ratio is observed among women younger than age 40. It's really disheartening, but this is what the results are showing. And no matter how you turn this model, this is the most striking finding about this. On the other hand, and again, this is after having removed the unknown stage cancers, women who are older are less likely than those who are in the 50 to 64 age group to be diagnosed with advanced stage cancer. Moving on to race and adjusting for age and many, many other things. No matter what you adjust for, African American women are 30% more likely to be diagnosed with advanced stage cancer than their Caucasian counterparts. So that's another finding that remains consistent no matter how we put our SES measures together, how we accounted for or did not account for some measures. These were very robust findings. Now, in terms of SES measures, so on this slide, you see individual level characteristics. So this is at the Census Block group level. The measures that remained significantly associated with advanced stage cancer was poverty, increased poverty being associated with a greater likelihood of being diagnosed with advanced stage cancer, although we didn't quite see the dose response that we were hoping to see. And however, at the fourth quartile, what this is telling us is that those in census block groups that have the worst level of poverty are 12% more likely than those living in better off areas to be diagnosed with advanced stage cancer. Now, I don't know why the third quartile, it's pretty close to being significant, borderline significant, but it's not quite significant.
For the census data, the SES data, was it race specific? So for instance, income level?
It maybe not. It was definitely age and sex specific. I need to find out because it may have been adjusted for race, and I need to make sure though. That's a great point.
I've looked at some income data, and it's drastic. I mean,
Very different, yeah.
yes,
Yeah, sure.
for all
Sure.
the different census blocks,
Sure.
tracts, if you look at it, and then, you know, it wouldn't be accounting then for, in other words, the difference in race, if the income is only being looked at,
Yeah,
in the census
in
terms
total,
of
yeah.
Caucasians, then.
Right. No, it's not just Caucasians, that's for sure, but whether we adjust it for the mix of the population, I need to find out. That's a great point. Thank you. The other SES measures were not significant at the census block group level. No association with high school diploma, having high school diploma, being unemployed, or being a female-headed household. At the contextual level, and again, adjusting for everything else and also adjusting for SES measures at the census block group level, we still saw these effects, which were significant, highly significant in fact. So for, this goes into poverty, again, no high school diploma, unemployed, and female-headed household. So adjusting for everything else, women in the higher poverty levels were 10 to 22% more likely to be diagnosed with advanced stage cancer. Same with census tracts where we had higher proportions of women with no high school. We also saw effects of unemployment and being in female-headed household. And again, this is after adjusting for the individual level characteristics and for SES measures at the census block group level. Also, adjusting for everything else, no matter which category you belong to, living in an MUA or MUP area increased your likelihood of being diagnosed with advanced stage cancer by at least 10%, 10 to 11%. So that remains significant as well. Interestingly though, being in Appalachian area or metro versus non-metro was not significant, although it came close in some instances.
Siran?
Yeah.
If you dropped out the variable medically underserved area and then analyzed area of residence, did those results then pop out? Did those change greatly? Because I'm wondering if the medically underserved area washed out the effect of area of residence. You know, you'd have to compare the models.
Right. You know, David, we ran so many models. I'll have to see if this was one of the models, and that's a great point, because you wonder if, like you said, MUA is probably absorbing a lot of that as well. Yeah, we did run a lot of models, putting this in, taking it out, going back. It was very messy, and at some point we had all of these SES measures in the same models, and it was a lot of correlations to deal with, and we decided to go with them this way.
It's not easy.
But yeah.
Have you ever considered just coming up maybe with a composite variable?
Yeah, it was Sue's idea. And we did, yes, we did. Okay, so this model, this is an alternative model where we use composite measures, and we derive the composite measures by taking, for example, in the case of poverty, we take the poverty percentage, we take the mean, we subtract the mean, and then we divide it by the standard deviation. So it was a bunch of z-scores that we added up, and then we did a quartile. And we did that at the block group level, and we did that at the census tract level as well. Now, putting the correlation between the census block group level composite SES and the census tract level composite SES was like 0.7, 0.8. So we couldn't put both in the same model. So in this particular model, we only accounted for the Census Block Group SES composite measure. Okay, so so this is with that composite measure, and in addition to the MUA and the county of residence, we also put in some of the variables that we pulled from the VRFSS data. So in this case, we actually we included all 4 variables: mammography, whether somebody had a personal doctor that they would go to, whether the cost was too prohibitive for them to go seek care, and whether they had health care coverage. And mammography and having a personal doctor were not significant, so I did not include the results here. But this is the model, and the results that you see on these 2 slides come from the same model, again, a hierarchical model. So no surprise here in terms of age and race. Marital status here was significant. Being married was had a protective effect against being diagnosed with advanced stage cancer. At the SES measure, and it was nicer in that we saw the gradient come out nicely. So this is Q1 being best to Q4 being worst. So women in block groups that had Q4 composite score were 8% more likely than those who were better off to be diagnosed with advanced stage cancer, and then 11% greater likelihood. County of residence was again not significant. MUA came out significant again at 8% rather than 11% to 13%. Prohibitive costs. So we just ran some of these analyses. So we'll do something to do in such a way that Q4 is always worse or is always better or whatever. But in this case, we didn't have a chance to do it. But for prohibitive costs, so Q4 is better. Those in the Q4, and this is at the county level, and bear with me here, and we'll talk about this in a minute, and I would love to hear some advice from others how to deal with this. But we had this measure at the county level only, and we had to assume that all the census tracts within that county had the same level for these measures. Okay, that this was uniformly distributed across all of the census tracts within that county. And so women who were in the best areas in terms of prohibitive costs, it cost us too high for them to go seek care, were 21% less likely to be diagnosed with advanced stage cancer, which was highly significant. For healthcare coverage, we only saw statistical significance at Q3. I don't know why it didn't follow with Q4, and it was borderline significant, but those with at Q3, so this means that there was a higher number of women without healthcare coverage, were 16% more likely to be diagnosed with advanced stage cancer, adjusting for everything else. So that's the composite story. And by the way, no cross-level interactions were detected. No interactions between individual and contextual level factors. Any questions? Yes, Amy.
Siran is really interesting to put it all together.